So this is a nice little summary of what's actually happening and showing those neurotransmitters that we've talked about. So we'll start somatic, okay, down at the bottom, somatic nervous system. Here it comes, skeletal muscle, that is acetylcholine. Okay. We then go up to the parasympathetic. Acetylcholine is being released from the presynaptic neuron and acetylcholine from the postsynaptic neuron. We then look at the sympathetic, and you can see again the presynaptic releases acetylcholine, the postsynaptic usually releases noradrenaline. A couple of places release acetylcholine. But also the presynaptic releases acetylcholine directly onto the adrenal gland, where it releases adrenaline and to a lesser extent noradrenaline into the bloodstream. What I'd like you to do now is just at each of these little places, so just at this point, you know, the autonomic ganglia and the effector area, just name the receptor for each. So for example, this first one, we're part of the autonomic nervous system, so what kind of receptor is that? Well, that is a nicotinic cholinergic receptor. Oh, okay, so press pause, don't look at what I just did. So that one's a nicotinic cholinergic receptor. I want you to press pause and just have a think about each one now. Okay, so hopefully you did think about that without looking at my accidental error of going a bit fast. So what you can see here is, if you're looking at the parasympathetic nervous system, you can see it's a cholinergic receptor, nicotinic cholinergic receptor at the preganglionic neuron, or the autonomic ganglia rather. Same thing with the sympathetic, and the same thing at the adrenal medulla. So you can see all of these are nicotinic receptors. They're all at the autonomic ganglia or at the adrenal gland in the case of adrenaline, and they're all of the neuronal subtype. You've then got the cholinergic receptor at the end organ, that is muscarinic, M1 to M5, so there are 5 different types, depending on what effects they're going to have on the various organs, so speeding up, slowing down, whatever it might be. You've got the adrenergic receptors, so that's the sympathetic division, so they're the alpha-beta and the subdivisions of alpha-beta, so they're responding to noradrenaline. You've got the cholinergic receptor down here, which again is nicotinic. This is somatic nervous system, so skeletal muscle, so therefore it's the muscle subtype. So really, if we're looking at a summary of those various receptor types, okay, you're thinking about the adrenergic receptors. They're alpha, beta, and split into alpha 1, alpha 2, beta 1, and 2, and 3. All very, very important because different drugs work at different receptors and therefore have different effects. If we're thinking about the cholinergic receptors, they're activated by acetylcholine. They can either be muscarinic, so they're going M1 to M5, or they can be nicotinic, where they're either the neuronal subtypes or the muscle subtype. So all the stuff that we've just gone through. And another important point is that these adrenergic receptors are found throughout the body, depending on what the effect of noradrenaline or adrenaline on the receptor is going to be. So where can drugs act? Well, drugs can act anywhere, so they can be relatively specific to any one receptor subtype, or they can be very generic. For example, they may activate all of the muscarinic subtypes M1 to M5, for example. And so in other words, you may have drugs that enhance their mimetics or block lytic autonomic function. So therefore we can try and target or stimulate or inhibit various aspects of the parasympathetic nervous system or the sympathetic nervous system, either more generically with a generic drug or specifically with a more specific drug to a specific subtype. So that's quite obvious. They can either stimulate or inhibit the parasympathetic nervous system or stimulate or inhibit the sympathetic nervous system. So the first thing we're going to go through now is we're going to go through cholinergic synapse pharmacology. So remember what we're thinking about with cholinergic synapse pharmacology. We're thinking about the effects of acetylcholine. But the first thing we really have to do is have a little look at the cholinergic synapse, because you need to have that information before you can move forwards and understand how it all works. So remember, when you get, so we're at a cholinergic synapse, we get an action potential coming down. And that action potential causes the release of acetylcholine from the synaptic vesicle into the synaptic cleft, where it binds to the acetylcholine receptor and goes on to have an effect in the postsynaptic cell. Now that acetylcholine can either diffuse away or it can be degraded by acetylcholine esterase, so ACHE, and that is broken down into choline and acetic acid, and the choline can get taken back up into the cell, react with acetyl-CoA to form acetylcholine again, and get taken back up into the vesicle. So really what the acetylcholine esterase is doing is breaking down the acetylcholine, so it's basically hanging around in the junction for less time. And of course, when we're looking at this, drugs could potentially work at any of these places. We could have something that stops the acetylcholine binding to the receptor. We could have something that stops the acetylcholine from being broken down. We could stop something that stops acetylcholine being taken back into the presynaptic neuron. And here are just a couple of examples of drugs that are used, some of them clinically, some more in research environments, but a couple of drugs that work in these different places. So the first one is hemicolium. So this, as you can see from where I'm pointing it to, it acts on the choline transporter, blocking the reuptake of choline. And by doing this, it reduces the amount of choline that is available within the presynaptic cell to make more acetylcholine. And therefore, you're reducing the amount of acetylcholine in the presynaptic neuron. Remembering, of course, that there's plenty coming down from the cell body or the soma. So you make some that's coming down through this route, and some is being made because of recycling. And this drug tends to act at the neuromuscular junction, but also at the autonomic ganglia. But it is mainly a research-orientated drug. You then have the acetylcholinesterase inhibitors. And these, as the name suggests, inhibit the action of this enzyme, acetylcholinesterase. So if you're inhibiting this enzyme, you should be able to work out what's happening. You get a buildup of acetylcholine in the synaptic cleft. Therefore, because it's remaining in the synaptic cleft for longer, you're getting an increase in the levels of acetylcholine and an increase in the duration of acetylcholine action. And so acetylcholinesterase inhibitors, they may be applied in the diagnostic and treatment of a variety of diseases like myasthenia gravis, Alzheimer's disease, bladder distension, glaucoma. There are all manner of diseases where acetylcholinesterase inhibitors are used. The next one, atropine. So you may have heard of atropine as well. And so what this does, it blocks acetylcholine binding to its receptor. And therefore it's inhibiting the propagation of a signal into the postsynaptic neuron. And when might this be used? Well, injection is given before anesthesia, for example, to decrease mucus secretions, such as saliva. And during anesthesia and surgery, atropine may be used to help keep a heartbeat normal. So there are multiple potential reasons why someone or clinicians may use atropine. Next one, tubocararine. So this is curare. So this is something that we mentioned a little bit earlier. And in the mid-1900s, this was used in conjunction with anesthetics to provide skeletal muscle relaxation during surgery or mechanical ventilation. But remember, it doesn't inhibit pain. It blocks the nicotinic cholinergic receptors. Another one you'll have heard of, botulinum or botulinum toxin. So this blocks the release of acetylcholine from the presynaptic neuron at the neuromuscular junction, and by doing this, of course, is causing a type of flaccid paralysis. So it's used clinically to treat a number of disorders characterized by overactive muscle movement, including post-stroke spasticity or post-spinal cord injury spasticity, spasm of the head and neck, eyelids, limbs, jaws, vocal cords, vagina. It's used in a number of situations. Last one we're going to look at is vesamicol, and this is more of an experimental drug, so you really don't need to worry about it too much, but it acts presynaptically by inhibiting acetylcholine uptake into the synaptic vesicles. Therefore, as less acetylcholine is getting in, you're getting less acetylcholine release. So it's more of an experimental drug, but potentially, I guess, it could be used in the treatment of adenocarcinoma in situ of the lung, for example, is examples you might see written around the place. But it's more of an experimental drug at this stage. So what are some of the problems with anticholinergic effects of drugs? So some people may have exposure to anticholinergic chemicals to excess, and that can therefore result in understimulation of cholinergic receptors because we're inhibiting those cholinergic receptors. And a whole series of effects that people might have with that. And that's shown in this nice little diagram down here that we're going to go through anyway. So you may be hot as a hare, so body temperature increases. Maybe blind as a bat, so leading to dilated pupils. Dry as a bone, dry mouth, dry eyes, decreased sweat. Red as a beet, flushed face, that should say, not fact, flushed face. And mad as a hatter, so confusion and delirium. And all of this is more accurately termed anticholinergic toxidrome, but it's associated with four main drug types, the four antis, if you like: antihistamines, antipsychotics, antidepressants, and anti-Parkinsonian drugs. So as well as having anticholinergic effects of drugs, you can have cholinergic effects of drugs, where you've been exposed to excessive cholinergic receptor stimulation. And so therefore we're thinking, what are the common features of this? So this is where another acronym comes in. So dumbbells. Okay, so the D, diarrhea, U, urination, M, small pupils, bradycardia, vomiting, lacrimation, so tears, lethargy, muscle weakness, salivation, and sweating. I mean, this can potentially be due to mushroom poisoning. Remember, muscarine, particularly if it's a poisonous fungi. Some insecticides can also cause it. But clinically and in medicine, it's more often seen in myasthenia gravis patients who take too high doses of medications, such as the cholinesterase inhibitors, which of course, as we talked about, increases the acetylcholine duration and levels. But it can also be seen when too high a dose of cholinesterase inhibitor drugs are given to reverse surgical muscle paralysis. There are a couple of places where it can potentially be seen. And as I said, overall, if it's too bad, muscles may stop responding to acetylcholine, leading to paralysis and potentially respiratory failure. So these are two little acronyms that you really should know about, okay, in terms of drug effects: anticholinergic and the cholinergic, which is probably a more important one for you to remember. So we've done the cholinergic drugs. So remember, we're thinking about adrenaline, and we're thinking about acetylcholine. And now we're going to go on to the adrenergic effects. So we're thinking about noradrenaline effects and adrenaline when we're thinking about the hormone. But first of all, we need to really know about the adrenergic synapse. So this looks a little bit complex, so we'll try and simplify it a little bit for you. So here's our presynaptic neuron. Okay, and the whole point about this really is that the first stage is noradrenaline. So this is numbers 1 and 2. So remember, norepinephrine is the same as noradrenaline. So noradrenaline is synthesized and stored in the synaptic vesicles. Now it's made from tyrosine, which goes on to form dopa, then dopamine. Dopamine is transported into the vesicle, where it is then converted enzymatically into noradrenaline. Okay, and so that's the first stage. Noradrenaline, on appropriate signal, so action potential is coming down. Noradrenaline is released into the synaptic cleft, so that's this little area here between the presynaptic neuron and the postsynaptic neuron, and it binds its receptor to elicit an effect, and that's there. So it's stimulating the postsynaptic neuron to have its effect. But what happens to that noradrenaline? So noradrenaline can then be recycled, so it can go on to bind to a presynaptic receptor where it actually inhibits its own release. So at this stage, the more adrenaline you get in this synaptic cleft, the more will bind to the presynaptic receptor, and therefore the more inhibition of the release of more noradrenaline you will get. So it's like a negative inhibition system. So it's quite nice in that respect. But by the same token, it may also diffuse away, so it can be disappeared because it just diffuses away. Or it may be degraded, so there are enzymes. So here's one, COMT, catechol-O-methyl transferase, so it can be degraded by that, and then further by MAO, monoamine oxidase, and then it can form inactive metabolites which go to the urine. But by the same token, noradrenaline can also get retaken up or recaptured into the presynaptic neuron. And so once noradrenaline has been taken back into the presynaptic neuron, it can be recycled, so go back into this vesicle, or it can be degraded by monoamine oxidase that we've already talked about, released as inactive metabolites, which then go on and pass into the urine. So it can either be reused or it can be degraded once it's come into the presynaptic neuron. And this is the most common route for it to be used. Okay, so most noradrenaline comes back into the presynaptic neuron. Less of it is degraded in the synaptic space. But the important thing about this is you're getting this negative inhibition going on. So what are some of the clinically important adrenergic effects? And what I've tried to do here is really just summarize it for you, so you haven't got a massive information that you've got to try and understand, because pharmacology is quite complex and it's an area that people struggle with. So I'll try to summarize this as best as I can. So the important adrenergic effects. If your noradrenaline or adrenaline binds to beta-1 adrenergic receptors, that increases your heart rate and increases myocardial contractility. So in other words, increases heart rate, stroke volume, and therefore cardiac output is also increased. It also stimulates renin release by the kidney. And so renin, remember, is involved in your renin-angiotensin-aldosterone system and is involved in long-term blood pressure regulation. It will affect the beta-2 adrenergic receptors. So it will cause relaxation of bronchiolar smooth muscles. In other words, it's leading to bronchodilation and therefore more potential delivery of air into the lungs, which you would want during a sympathetic response. It causes direct vasodilation in the heart, the skeletal muscle, and the liver. And if you're thinking about the heart and the skeletal muscle, that's particularly important because vasodilation to those tissues is important during that fight or flight response. Your heart needs more nutrients. Your skeletal muscle needs more nutrients to be able to fight or to run. You've got the beta-3 adrenergic receptors. Stimulates lipolysis in adipose tissue. So again, during that fight or flight response, your body's going to need more energy. So it stimulates fat breakdown to free fatty acids, which can be used as an energy source by multiple tissues. You have the alpha-1 adrenergic receptors. They constrict blood vessels. So for example, constriction of blood vessels to the GI tract, the kidneys, and non-essential systems during that fight and flight. So the important thing really with blood vessels is you're getting vasodilation through beta-2 adrenergic receptors to the heart and skeletal muscle in particular, and it's constricting the non-essential blood vessels. Okay, as I said, GI tract, kidneys, and other reproductive organs, so the non-essential systems. Finally, the alpha-2 adrenergic receptors, they are the ones that are involved in autoregulatory feedback inhibition of noradrenaline release. So in other words, these are the ones that are on the presynaptic neurons. Remember, noradrenaline binds to these alpha-2 adrenergic receptors on the presynaptic neuron and inhibits release of more noradrenaline from that presynaptic neuron. So it's all involved with negative feedback. So the last little bit that we're going to do today is we're just going to summarize the main interactions of the autonomic nervous system. So how is the autonomic nervous system controlled is what we're really thinking about in a lot of ways. So if we're thinking about sympathetic and parasympathetic tone, the sympathetic nervous system controls blood pressure even at rest. Okay, so short term it's helping to regulate those fluctuations, because long term it's done by blood volume, short term it has to be done for vasodilation, vasoconstriction, increase in heart rate and contractility. So what happens is the sympathetic division controls that blood pressure. And so the vascular system, with the exception of the reproductive system, is almost entirely innervated by sympathetic fibers. And what's called sympathetic tone is basically the blood vessels are in a continual state of partial constriction, which means that they can be constricted more to increase blood pressure further, or relaxed, therefore dilated, to lower blood pressure. So what happens when your blood pressure is too low or too high? Well, if your blood pressure is too low, your sympathetic fibers fire and they constrict the blood vessels to cause vasoconstriction. And if it's too high, your firing decreases and you allow blood vessel relaxation, causing your blood pressure to drop. The parasympathetic nervous system normally dominates the heart, the smooth muscle of the GI and urinary tract organs, and activates most glands, except the adrenal glands, the sweat glands. And remember, it also doesn't innervate the majority of your vascular system. So therefore, drugs that block parasympathetic responses increase heart rate and cause fecal and urinary retention, because we've talked about what the functions of the parasympathetic are and what the functions of the sympathetic nervous system are. But how is all of this process controlled? Well, actually, it's the hypothalamus that has overall control of the autonomic nervous system. It's the main integration center. It governs that brainstem function. So it is basically governing it's monitoring what's going on in the body, and it's responding to that. So it regulates heart activity and blood pressure, body temperature, water balance, so the amount of hormones that are released, for example, antidiuretic hormone, and endocrine activity, for example, your metabolic rate. It does all manner of things. And it mediates your reactions to fear via the limbic system, which is the system within your brain that's to do with emotions and fear. But you can see just from this the other areas that it's controlling. So feeding, fullness, your GI tract, your shiver reflexes, your water balance and your stress. If you're thinking about cortisol release, that's all being stimulated from the hypothalamus. Your water balance, it stimulates the release of antidiuretic hormone. It helps to regulate your blood pressure and your body temperature. Remember, thinking about the thyroid hormone. And there are a variety of other roles as well. For sleep-wake cycle, it has an important role in your sleep-wake cycle. It has an important role in the release of many other hormones. So the gonadotropins, the ones involved in reproduction, for example. So there are lots and lots of different roles that the hypothalamus has control of. It's basically helping to control the autonomic nervous system and your homeostasis. So the cerebral, cortical and spinal controls as well. This is what we're just going to finally finish on. So voluntary cortical controls allow connections between the cerebral cortex and the limbic system. Remember, that's your emotional system, your fear system, to communicate with the hypothalamus. So for example, if you have a thought of a frightening event, your sympathetic response will be to increase heart rate. Thought of a favorite food, your parasympathetic response will to make your mouth water. So therefore you're having a thought of something, voluntary controls, but it's collaborating with the autonomic nervous system. And the same thing with defecation and micturition, which is weeing. Those reflexes are integrated at the spinal cord level. So they are reflexes that allow smooth muscle to change its tone, but they're subject to conscious inhibition. We can prevent ourselves from having a wee or having a poo. Okay, so we have that conscious control.